The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, and welcome to today's webinar on exercise and sports in the cardiomyopathy patient, hosted by the Children's Cardiomyopathy Foundation. We're glad that you're joining us this afternoon and hope that you find the presentation helpful and informative. My name is Gina Petty. I'm the Director of Family Support and Outreach at the Children's Cardiomyopathy Foundation. If this is your first time joining us for a webinar, welcome. We're glad that you're here. Before I turn the presentation over to our guest presenters, we have a few housekeeping notes. If at any point during the presentation you need any technical assistance, please type your concern in the chat window, which is on your control panel on the right-hand side of your screen. If you have any audio issues, you will be able to switch your audio between using your computer speakers and your phone if needed. So just click on your audio tab in your control panel. In order to provide the highest quality session today and to avoid any background noises, all attendees are in listen-only mode. Your questions are encouraged and welcome. Questions can be submitted via the question box located in your control panel. We'll be taking questions during the second portion of the presentation, so please feel free to submit them as you think of them, and then Drs. Day and Dr. Lampert will review them at the end of the talk. We'll also be recording this webinar, so you'll be able to access the information again at a later date. And now I'd like to introduce our presenters. Sharlene Day graduated from the Massachusetts Institute of Technology and received her MD from New York University School of Medicine. She completed internal medicine residency, cardiovascular medicine fellowship, and a postdoctoral research fellowship at the University of Michigan. Dr. Day's clinical and research programs focus on inherited cardiomyopathies. She has been treating patients and their families with hypertrophic cardiomyopathy and other genetic heart conditions in a dedicated clinic that she started in 2007. Dr. Day is a founding investigator for the Sarcomeric Human Cardiomyopathy Registry, or the SHARE Registry, a large-scale international registry of hypertrophic and dilated cardiomyopathies with prospective longitudinal follow-up. A major focus of her clinical research is determining the importance of fitness for patients with HCM, establishing evidence-based guidelines to inform recommendations for athletes with cardiomyopathies, and promoting a shared decision-making model for athlete participation. She has led the first randomized clinical trial of exercise training in HCM patients and showed that moderate intensity training improved exercise capacity in HCM patients without causing arrhythmias. Dr. Day also heads a basic translational research program focused on understanding the underlying biology of HCM, in particular how mutations in sarcomere genes trigger and perpetuate disease. Rachel Lampert, MD, is a cardiologist with Yale Medicine who specializes in electrophysiology. She treats patients with arrhythmias, syncope, palpitations, and other related conditions. Many of them are athletes who are thinking of getting back into the game or patients with a terminal diagnosis who are hoping to maintain a good quality of life. Many of her research questions have been inspired by patient questions. For example, many have asked which of the lifestyle restrictions for patients with medical devices are necessary. Dr. Lampert has collected data and has since published several papers on this topic. In addition to seeing patients and conducting research, Dr. Lampert teaches at the Yale School of Medicine as a professor of internal medicine, cardiology, and serves as an active member of the Heart Rhythm Society, American College of Cardiology, and the Leadership Council for Sports and Exercise. We are so grateful to have you both joining us today, and welcome to you both. Thank you so much for being here.
Thank you. Well, thank you so much, Gina, for inviting us. So this is Sharlene Day. I'm going to start. You can tell me. I'm going to try and put this in slideshow mode so can you see my screen now?
Yes. Thank you.
Okay, great. So welcome everybody to the webinar. We're so delighted that you're interested in this topic. This is something that that Dr. Lampert and I have been very actively considering and researching for patients with cardiomyopathy. This question about level of exercise and how exercise can be beneficial, whether there's any risks associated with it. And so we're going to talk to you about that today. So first of all, I wanted to define what we consider exercise to be. So we think about exercise in different categories. Broadly speaking, you can categorize it into recreational or competitive exercise or competitive sports participation. So in general, recreational exercise tends to be a little bit maybe lighter intensity, maybe slower pace. We think of competitive sports as being higher intensity, faster pace. Although there's certainly a lot of overlap, and we know that there are people that do road races, for example, that might be kind of back of the pack runners, even though they are technically competing, but they maybe not quite have the same mindset as those who are at the front and trying to win or set a personal record. And on the other hand, there's certainly recreational athletes that don't necessarily participate in a competitive way. They don't compete against others, but they might exercise very, very hard and intensely, even though it's considered for them to be recreational. So I think it's important to consider that these are not two distinct categories, but indeed there is a lot of overlap between them. So for over a decade now, there have been guidelines that have in many ways provided a foundation on which to base recommendations for patients or athletes with hypertrophic cardiomyopathy or dilated cardiomyopathy. These particular guidelines I'm showing here pertain to competitive sports participation. And the first set of guidelines was the 35th Bethesda Conference in 2005, and there was a parallel set of guidelines from the European Society of Cardiology, and then an updated set of guidelines from the United States in 2015. And essentially, all of these guideline documents have recommended universal exclusion from most competitive sports for athletes with cardiomyopathy. In the most current set of guidelines, there was an additional clause that said that these recommendations do not strictly exclude in absolute terms fully informed athletes from participating in competitive athletic programs. And that leaves some room for some flexibility, individual responsibility, and informed decision making. And that's something we're going to talk about over the course of this presentation. So there are also some published guidelines for recreational exercise. These have not been updated and are now 14 years old. But in general, this guideline document ranked sports according to level of intensity. Even though they were being done at a recreational level, the guidelines advise against doing those types of sports that involved anaerobic activity, burst exertion, isometric, such as heavy weightlifting, or if there is a risk for trauma-related injury if consciousness became impaired. And then there were ones that were in the moderate category, and then there were ones that were in the permitted category, meaning they were maybe lower or moderate intensity, although you can certainly imagine that people would bring different levels of sort of intensity to a particular sport, such as swimming or biking, and those can be done at varying levels of rigor. So these guidelines provided, again, some foundation, but we Dr. Lampert and I have been in many ways sort of challenging these guidelines because they're really not based on any data. And when I say data, what I mean is there haven't, up to this point, had not been any studies that looked prospectively at patients with cardiomyopathy who were participating in sports or doing recreational exercise at different levels. And so, of course, the concern and really what's driven these guideline documents has been the potential risk of a sudden cardiac arrest or even the sudden cardiac death being triggered by exertion. And here are some examples of some individuals, very high-profile athletes, who died suddenly, and in this case, all of the 4 athletes shown here were found to have hypertrophic cardiomyopathy either prior to or following their tragic death. And so certainly these high-profile deaths have raised the possibility that intense exercise in particular could trigger one of these very dangerous heart arrhythmias. But over the years, what we've realized is that these sudden cardiac arrests or sudden deaths that occur really completely out of the blue, even in athletes who have trained and competed for many, many years, and it's not really clear what triggers them. And in fact, most sudden cardiac arrests or deaths in patients with cardiomyopathy don't occur when they're exerting themselves vigorously, but instead can occur while they're not doing anything at all. So they could be sleeping, they could be sitting at lunch, talking to friends, walking to class. So I think that's caused us, to reevaluate whether these guidelines really make sense in light of some of the data that we're going to show you in the next few slides here. So there have been a number of studies that have looked at the population level. So these are studies that have looked at large populations in various geographical locations and then counted the number of sudden cardiac arrests or sudden cardiac deaths that occurred in that particular population. Some of these are in the general population, some of these are in athlete-specific populations, but what they've all found over the last decade or so is that the incidence of sudden cardiac arrest is very, very low overall. And I'm showing you in this particular slide because HCM has previously considered to be the most common cause of sudden cardiac arrest in the young. That's really been, I think, effectively disproven at this point based on recent studies. And in fact, the risk associated of sudden cardiac arrest attributed to hypertrophic cardiomyopathy in population is somewhere in the order of 0.5 to 0.6 per 100,000 individuals. So that means that the estimated annual incidence in HCM patients, for example, is 0.2 to 0.3%. So this is very low and much lower than I think was the perceived risk at the time that the guideline documents were written. In this particular study that I'm highlighting, HCM accounted for only 3% of all sudden cardiac arrests and about 10% in a younger age group. And as many studies have shown, most of the sudden cardiac arrests occur in males as opposed to females. And while some of them did occur during or following vigorous activity, about a third, others, the majority, occurred during routine daily activities at rest or while sleeping. So the question then becomes, what is the risk for a sudden cardiac death or arrest for individuals if they have a known diagnosis of HCM or DCM, and if they choose to engage in vigorous or competitive activity? And the question then to follow is their risk any higher than in individuals who are less active? So for example, if you or your child has a cardiomyopathy and you come to see their doctor and you ask the question, what is my risk if I participate in sports? And what is it if I don't participate, if I choose to withdraw? And right now we don't have the answers to those questions, but something that we're actively seeking to learn. So this is a study that Dr. Lampert done. Dr. Lampert, were you going to show this at all? Because I can skip it if you were.
No, I wasn't actually going to show this, so please go ahead.
Okay, so this was, I was not involved in the study, but this is Dr. Lampert's work in the ICD Sports Registry, where she and her colleagues looked at the safety of sports for patients with implantable defibrillators. There were a number of different diagnoses of 372 athletes overall doing more than low intensity sports. 65 of them had hypertrophic cardiomyopathy and 31 of them had dilated cardiomyopathy. And what she and her colleagues found is that there was no occurrences of the primary endpoint, which was a combined endpoint of deaths or a resuscitated cardiac arrest or a shock-related injury. They noted that more shocks occurred during physical activity, but that there was not a difference between competition and practice or just kind of normal recreational physical activity. And the majority of athletes who experienced shocks from the defibrillator chose to continue to play. So obviously, this was something that was really important to them. And their rates of shocks were similar to those reported for less active ICD populations. So I think another question that's clearly needs to be answered, and now there's a couple of studies recently that have looked at this, is what happens to athletes if they choose to stop playing or if they are quote unquote disqualified from playing versus if they continue to play competitive sports. And there are two recent studies that have been published in the last 6 months that have shown no difference in event rates, meaning that the cardiac arrests or abnormal heart rhythms didn't occur more commonly in athletes that kept playing versus those that chose to stop playing. So I think it's still very early to know for sure, and the numbers of patients enrolled in these studies is still very small. But I think it raises some important questions about the consequences of disqualifying athletes or recommending that they stop participating in sports, and whether we are truly lowering their risk of having a cardiac arrest to sudden death, which again is overall a very low incidence and a very rare event. So this is what Dr. Lampert's going to talk about, but this is something, these are questions that have inspired a design of the study called LIVE, the Lifestyle and Exercise Study in Hypertrophic Cardiomyopathy. And we also have a parallel study in long QT syndrome, which is an inherited arrhythmia syndrome. And so Dr. Lampert will expand on this later, but I just wanted to bring this up now as a prelude because these are really the questions that we're trying to answer in this study in terms of long-term outcomes in those participating in sports, recreational exercise or not, and also the effects on quality of life of an individual's lifestyle. So when we're considering the potential negative consequences of recommending that children or adults cease participation in either competitive sports or recreational exercise, I think it's important to consider what we're also taking away from them. And certainly for children in particular, I think there are a lot of benefits, a lot of things that they learn for participation in organized sports. We know that physically active children are more likely to become physically active adults. And it's been shown that they're less likely to be obese, to engage in smoking or other risky behaviors. They're more likely to go to college. So being active as a child, I think, is incredibly important for their overall longitudinal health. And we also know that organized sports build a lot of qualities that are really important life skills, including leadership and teamwork, coping, setting goals, focusing, cooperating with teammates, and social skills. So we really have to think about the detrimental effects of recommending to cease participation in organized sports. So we really have to be very careful not to take these children and to make them these children and to ultimately make them these adults. I think continuing to support children and adults in an active lifestyle is really important. So I'm just going to turn now to how we advise somebody with a cardiomyopathy who is not necessarily interested in doing athletic, highly athletic or participating in competitive sports, but how we advise them in terms of what sort of exercise program they should be following. So we actively promote a moderate intensity exercise program at least the American Heart Association recommended minimum of 150 minutes per week. In a study that we published a number of years ago, we found that patients with hypertrophic cardiomyopathy specifically were less active than the general population, that many of them had reduced their exercise following their diagnosis, often at the advice of their medical providers, and that this had had a negative emotional impact for them. And we also found that HCM patients in particular had a higher body mass index than the national population. So we know that that obviously has detrimental health implications. In another study, this was published 2 years ago by a group in Australia, they found that only 45% of patients with hypertrophic cardiomyopathy were performing exercise at or above the recommended 150-minute guideline of moderate or vigorous activity, and 16% of patients that presented to their clinic had been told that they shouldn't exercise at all. Dr. Saberi and I, along with colleagues at Stanford, Dr. Wheeler and Dr. Ashley, many years ago designed a randomized clinical trial to look at moderate intensity exercise in HCM patients, because at the time there really were no data to guide recommendations for regular exercise. And I just have this one slide to summarize what we found. So the design of the trial was 136 patients were ultimately with hypertrophic cardiomyopathy were randomized to either a moderate intensity exercise program or to their usual activity, which could involve some exercise, but whatever they were doing before the trial started. This was an adult population, so we had an average age of 50, but the range was 18 to 80, and 42% of them were women. Overall, what the trial showed was that moderate intensity exercise improved functional capacity. We did not see any serious adverse events, which means there were no heart arrhythmias, and we did not see any difference in what we called non-fatal or non-serious heart arrhythmias. So we are very encouraged by the results of this trial. And we think that it supports the incorporation of at least moderate exercise training into the lives of patients with hypertrophic cardiomyopathy. So what about dilated cardiomyopathy? Well, it's been known actually for a longer time that exercise is good for patients with dilated cardiomyopathy. There have been a number of studies looking at exercise training, and the largest one is called the HF Action Study, which enrolled a couple of thousand participants. So we know that exercise training for patients with dilated cardiomyopathy is safe, and we know it improves how people feel, how much they're able to exercise, what their quality of life is, and it also prolongs life. And so this is actually an approved diagnosis for cardiac rehabilitation programs. So this has been known for longer than for hypertrophic cardiomyopathy, but I would say now for both cardiomyopathies, we have good evidence that regular exercise is beneficial. So the way that we now approach patients is that those who are inactive, we recommend that they participate in light to moderate recreational activity. And for those that are interested in doing more vigorous or even competitive or high intensity sports, we employ something called a shared decision-making model. And this is really at the pinnacle of patient-centered care. The idea that rather than the clinician or the doctor being paternalistic and saying, this is what you should do, we discuss the potential risks and benefits with the patient, in this case, the athlete. We listen to the athlete and assess their importance and motivation for them continuing in sports. And then we talk about potential precautions that could be taken to make their training regimen as safe as possible. So the idea here is there is dialogue back and forth between the patient or the athlete and the clinician to make a decision about whether they want to continue to participate in sports or whether they would like to take themselves out or do something else or maybe adapt their sport to their level of comfort. So we do discuss the importance of informing teammates. We would certainly not recommend that they go back to their team and participate without letting their coaches and their teammates know about their heart condition. We recommend that they not train alone and that there be an emergency preparedness plan or emergency action plan in the case that something did happen. So these are the types of things that we recommend for trying to make the training and environment as safe as possible. We recommend that there be an AED on site, an automatic external defibrillator, and that it's accessible, that the batteries are charged, and that people know how to use it. That we recommend that athletes build an aerobic base. This is particularly important for, I think, adult athletes who tend to maybe not have a lot of time during the week and want to do something really intense on the weekend. So we recommend that they really try and do a consistent aerobic training program, that they heed warning signs if they don't feel well, that they stop and rest. Hydrate really well. This is very important for patients with cardiomyopathy. And for those that have defibrillators, consider wearing a heart rate monitor so they know that they'll keep their heart rate below the level at which the defibrillator could potentially deliver a shock inappropriately if it didn't recognize that it was their normal rhythm. So I have a few slides on pediatric considerations for sports participation. We certainly encourage active, healthy lifestyles and recreational sports in children. We will work with the child, the school, the coaches, and the parents regarding making sports choices, again, in a shared decision-making process that everybody is comfortable with. So here are, a few of our athletes who are participating with cardiomyopathies in sports actively. So for gym, many, I think historically, if I see many of the adult patients in my clinic were told many years ago that they couldn't participate in gym class and were given a note to say they couldn't play. And we certainly, at the current time, would not advocate that at all. We want them to be participating with their teammate or with their classmates. But we recommend that they not be graded in gym and that their participation be encouraged, but that the gym teacher knows about their condition and the child is allowed to rest if they need to rest and not be pushed beyond a limit that they're not comfortable with. And also recommending if activities need to be modified for their condition, that be allowed as well. We recommend the buddy plan, for the older kids that may be training on their own, that they exercise with a friend, that they be in a public place that's supervised, and that consider modifying sports as needed, either because their condition maybe not allow them to participate at a certain level, or just their level of comfort after a discussion about what potential risks might be to them and where there are areas of uncertainty. So I think I will stop there and I'll let Dr. Lampert pick up from there.
Okay, is my screen on at this time?
Not yet.
Do I need, hang on, do I need to do something to accept? I've got share my, do I need to do something to get the screen over to me, or, oh, here we go, show my screen,
Yeah.
okay. All right, now are you seeing the slides, lifestyle and exercise in HCM?
Now we are, yes.
Okay, and are you seeing like the next slide too, or you're just seeing the main slide?
We do see the next slide as well.
All right, let me just move it to the other screen because I think that's the problem.
Okay.
Hang on 1 second here. I can't get it to do it. Well, I think we'll have to see. Hang on, let me try one more time to see if I can get it to just show this screen. Let me put this over here. Hang on, I'm sorry, give me one more second here.
No, it's fine.
I'm gonna put this over on this screen and see if I can get it to work this way. All right. How about now?
We still see the next slide, but that's okay.
Oh, well, all right.
Just go ahead. Yeah.
All right. So as Dr. Day had discussed, at this time, we have pretty limited data on the safety of exercise and more vigorous exercise in hypertrophic cardiomyopathy. She went through the history of things. Guidelines have been pretty strict, really based on the idea that if we don't know how safe it is, we better be cautious. But there's some small series that have started to suggest it might be safer than has been thought. So a few years ago, Dr. Day and I and Dr. Michael Ackerman initiated a large study to try to actually get the answer to this question that's called Lifestyle and Exercise in HCM, or the LIVE-HCM study. So the purpose of this study is to determine how lifestyle and exercise impact the well-being, both physical and emotional, of people with hypertrophic cardiomyopathy. And we also have a parallel study for long QT, a different type of genetic heart problem. So the study is enrolling people who have hypertrophic cardiomyopathy or who have the gene for hypertrophic cardiomyopathy and a family member who has the actual heart manifestations. We had been enrolling age 8 to 50, or actually 8 to 60 at this time, and you'll see we're getting close. We're getting close enough to the end of the study that we're actually at this point really focusing on people who are age 8 to age 30. So we're really looking to enroll more of that younger group who have HCM as well as their parents. For this study, people can have an ICD or not have an ICD. So it's either way we're enrolling. Many people are enrolling as families. So since HCM, of course, is genetic, for most kids, one of their parents has it. And so usually like a child and parent, if there's other siblings, will all enroll together. Once in a while, for whatever reason, there might be a person that just has it without family members, and those people are welcome to participate as well. So we're enrolling individuals at any level of exercise. So whether you like to run, you're more active, you like to walk, you're a little active, you really just prefer to sit and read a book, whatever level of sports you're doing, we'd love to, or activities you're doing, we'd love to have you enroll in the study. So something that's important to just say again, we don't know whether vigorous exercise is safe. And as Dr. Day pointed out, the current guidelines don't recommend it. But we do know from surveys that she's done and others that people with HCM are participating in more vigorous sports anyway. So being in the study doesn't endorse competitive sports, but what we want to do is obtain information on the risks and benefits of exercise at all different levels by following individuals over time, both children and adults, at whatever level of exercise they're currently engaged in. So people can enroll in this study directly through the coordinating center, which is here at Yale. The study involves doing some questionnaires and interviews over the phone and over the internet. So there's no geographic constraints to participation. We do have some sites, and some people might have a doctor that is actually involved in the study, and then you can enroll through that doctor. But if not, you can enroll just through us here at the central site. So, and outside of the US, basically we have patients coming in from any English-speaking country, so Canada, England, Australia, and also New Zealand. So what does being in the study involve? There's not a lot of time commitment. There's some, but it's not an extensive amount of time to be in the study. So there's no extra testing, there's no blood work, there's no interventions. The way it works is that once we talk to you, you want to be in the study, we then you sign a consent form that includes letting us obtain medical records. So we obtain the medical records at enrollment. We have an echo that, depending where you're followed, we might have read by the core lab at Mayo Clinic. And then once you're actually enrolled, at the time of enrollment, there is a series of questionnaires that are done over the internet for those over 18, or by phone for the children under 18. The questionnaires, excuse me, are two parts. They involve a detailed look at activities, both what types of activities you're doing now, and also what you've done in the past, and also questionnaires that look at your how things are going as far as quality of life. In general, it takes about 20 to 40 minutes to do the questionnaires. It's okay to save and come back. So if you get started and you have to leave, you can always come back and do it later. The other part of the study involves wearing a Fitbit zip. So once we have all the baseline information, we then send you your zip that's registered through the study. We ask that you wear it at a minimum 2 weeks when you first enroll, and then 1 week every 3 months. Or you can also wear it as much as you like. And I think most particularly the kids, are wearing it really all the time because they think it's a fun part of this study. There's an optional wristband that most of the people use. It is the actual Fitbit is the clip-on one, but we do have a wristband that you can kind of snap in so that you can wear it on your wrist. And you can access your data on the website the same way as if you just gone out and bought a Fitbit. So you really can use it the same way you would if you had just bought it on your own. If you already have a Fitbit, it's fine to just wear your own. And then we talk about how we can pull in that information from your own Fitbit. So that's at the time of enrollment. And then over the 3 years of participation, there's a brief internet questionnaire every 6 months that asks how you or your child are doing. For the children in the study, we just ask the parents to fill out the brief questionnaire. And if there have been any events, anybody's been hospitalized, or if they have an ICD, it went off, or anything like that, we then contact your doctor to get the medical information about the event. So what we do is every 6 months we send out reminders and a link. And then you follow the link, and it's a pretty brief questionnaire every 6 months for the 3 years. So that's what it involves to be in the study. And then the study is progressing pretty well. We have our goal is about 2,250, and we have over 2,000 enrolled. Now we are at this time, we're looking, as I mentioned before, for younger participants, because we have met the number that we need for the older participants. And so we're really looking for the kids and the adolescents, the younger adults. I think that the participants in the study are enjoying being in. Here were some quotations that some of the participants had given us, and they gave their okay that we put these on slides and things. So this was a young adult who said, "The study captures the biggest question in my life right now." And this was the mother of some adolescents who said, "The study is helping empower my kids to take control of their diagnosis." So I think that family felt like they were doing something positive. I'm so excited to start the study. I think lots of people enjoy being in the study. And then from one 8-year-old, we heard, well, I'm having fun with the questions, but I'm really just doing it to get the Fitbit. So people have all kinds of reasons to be in the study, and that's fine too. So if you do want to participate in the study, you can contact us here at the Central Coordinating Center. Our email is live.hcm@yale.edu. We also have some information on the CCF website, so you can also contact us through them. We have 3 study coordinators, Teresa, Cheryl, and Sherry, who will talk to you in more detail about the study when you, if you do want to be in it and get in touch with us. So that is Live HCM, and at this point, I'm going to give the screen back. So now I want to share the screen back with you, Gina. Remind me, I'm going to sharing. I want to share the screen back. How do I do that? I'm not seeing it.
I can take it back, I think. Let's see.
Okay. Okay, thank you.
Okay, sure. Well, thank you both for that very informative presentation. That was great. We really appreciate you sharing your time and your expertise with us. We're going to open it up for questions now. So I've gotten a few questions already submitted, so I'll go ahead and I'll start with those. And in the meantime, if anyone else wants to submit a question, go ahead and on your control panel, there's the question tab on the bottom of the control box, and you can enter a question. So we'll just start with the list that we have and get through as many as we're able to in the time that we have. So the first question is about HCM. Can a child with HCM ride on roller coasters or other thrilling activities?
You know, that's a great question. One of my colleagues here at Yale, Dan Jacoby, is actually looking into that question right now. He's done a survey of HCM patients to see how many of them are riding on roller coasters and if there were any adverse events. So I think there will be some actual data on that fairly soon, whether, you know, it has caused people to get short of breath or have any symptoms, or whether they're doing just fine. Charlene, in the meantime, what would you recommend as far as the roller coasters?
I think this falls under the shared decision-making process, right? Where, we don't have information. We really, at this point, don't have any at all. But my sense is that the risk is exceedingly small. In terms of having a heart-related issue associated with riding roller coasters. Now, there's obviously risks to everything that we do every day, and I think trying to put things in perspective. I mean, there are risks to riding roller coasters that the roller coaster could break, right? There have been incidences of people that have been injured and or even killed in amusement parks. So not to be grim, but I mean, I think just in terms of putting in perspective, I think generally we think that amusement park, that going to amusement park rides is safe. And I think the risk is exceedingly small. So I typically am very supportive of children and adults riding roller coasters and other thrill-seeking activities. So it really just depends on their comfort level.
Mm-hmm. Okay, thank you. Another question is, during vigorous activity, how can you tell when an HCM child needs a break?
Charlene, do you want to take that one?
I can. I am an adult cardiologist, but I have learned a lot from my pediatric colleagues. That is a hard question. I think what I've been told repeatedly is that children don't really know what a symptom is. They don't recognize it because maybe they've always felt this way. So they might tell you, if you say, do you get short of breath? They say, well, no, I mean, it's just how I feel, but relative to their peers. I think one thing to look at is whether they're having trouble keeping up with their peers. But I think it is a hard question. I'm honestly not sure how to answer it other than to, directly observe them and, and if they do noticeably seem out of breath, that they're lagging, to recommend that they kind of pull back and rest. But I don't have a definitive answer to that question.
Okay.
I think it's a time maybe we're working closely. I mean, I think it depends too on the age. The younger the child is, obviously, the harder it is for them to recognize a symptom. But I think it's a time when maybe working closely with the gym teacher is important, because I suspect the gym teacher can probably start to tell when they're lagging or looking like they're having a harder time.
Mm-hmm. Okay, thank you. Another question is from a parent with an 8-year-old with dilated cardiomyopathy. This child loves trampolines. What category of intensity would that fall into?
That's a great question. So I go trampolining with my kids, and I see all levels of intensity. Some people do it as a form of exercise, and can be doing flips and all sorts of things. And other people are really just sort of jumping up and down very casually. So I think the level of intensity in trampolining, as with any activity, really can vary tremendously. So I don't know if I could really categorize it. I think it depends on what they're doing on the trampoline. I think for the most part, I would consider it, again, I would definitely endorse children doing it, but I don't know if I can. It has a lot of different levels of intensity that can be.
I think one thing that Sharlene was talking about that we sometimes think about more in adults, but I think is true in kids too, which is that a lot depends on your baseline level of activity. So if you have a kid who's like really active to start with and is in pretty good physical condition, then they're going to be able to do a fair amount on a trampoline. But if you have a kid who is generally not as active, and then all of a sudden they're going to really have fun on a trampoline and really, go to town, it's because it's, more fun than they're, it's such a fun thing that that I think plays into it as well.
Yeah. I think the level of conditioning for the child is very important in terms of how difficult any given activity will be for them.
Right. Okay. Great. So we've had a couple of questions that have come in regarding LVNC cardiomyopathy, and we had spoken about the webinar being focused on dilated and hypertrophic, and you can both probably say it more eloquently than I can, but I'm just going to read this question aloud for you to comment on. How do these guidelines apply to competitive athletes that have LVNC who are basically asymptomatic?
Yeah. So LVNC is, can be considered an isolated diagnosis, but it typically overlaps with dilated cardiomyopathy and sometimes even overlaps with hypertrophic cardiomyopathy. So I think, and I think it's also been increasingly recognized that there's, some level of non-compaction or what we call hypertrabeculation that could even be within the normal range or normal variant. But for people with isolated non-compaction, if they're not symptomatic and if they have normal squeezing function of their heart, we consider those individuals to be very, very low risk and would endorse them participating in sports. And I think, that would be, less controversial than maybe if they were more symptomatic or had more significant impairment in their heart function. But again, if they're asymptomatic, I think that in isolated non-compaction, generally that's considered a low risk condition.
Okay, great. Thank you. Another question, our cardiologist indicated that he felt that baseball was okay, but it is in the category that is not advised on the slide. We're thinking of introducing baseball to our 8-year-old son. Not sure if the level of intensity is less depending on what position you play in baseball as far as a recommendation.
Yeah, it's really hard to know. I think our pediatrician has gone through different phases of different recommendations, over the years, and I think initially was, would work with kids to maybe change their position within a given sport, or move from swimming to diving, or moving from a center to goalie in soccer, and we really have no information that increases or changes the quote unquote safety of the sport for that individual. I think I would use it, I present these options to parents and their children. And again, I think it's a level of comfort, but recognizing that we really don't have any data to say that changing the position or changing to a different sport or any particular sport is potentially carries a higher risk than any other. Baseball is one that I know that we have a number of children in our program who have played baseball. Generally speaking, it's a lower intensity sport than basketball or football or soccer. So
this is just the kind of question that our study is hoping to address as well.
Yeah.
Okay. Another question is, what are the dangers of mild dehydration in an HCM child during activity, especially when being out in the heat?
Yeah, that's one of the things that I really stress over and over again to the children, parents, and the teammates, that hydration is so important. And I really do advise that they avoid exercising or training in extreme environmental conditions, and particularly heat and humidity. I think it's dangerous for anybody, honestly, and we've certainly seen incidences of heat stroke, even fatal heat stroke, in football players practice in the summer. So and particularly for an individual with HCM, their cavity size is smaller, they're really more susceptible to heat related dehydration and illness. So I think trying to avoid long time of exposure to heat and really being highly attentive to hydration is important.
Mm-hmm. Okay. We have one more question, and I know Dr. Day has to get off the call in a minute, so maybe we can have one more question. For an 8-year-old boy with HCM, is there any increased risk if they are also diagnosed with ADHD, around what you just shared with the correlation piece of risk? Is there anything with ADHD as well?
Rachel, do you want to take that, or?
Well, that's another place where we really don't have the answer. As far as does taking ADHD itself, I don't think would impact the risk of sports, but would the ADHD meds increase the risk of sports? In general, there used to be a lot of concern about ADHD meds for anybody with an arrhythmic, with a type of heart condition that might put them at risk for arrhythmias, whether the cardiomyopathies or the purely electrical diseases. And in general, I think it hasn't borne out to the extent that people were concerned about. And again, I just have to say that's another question that I think we may have some data on from our study, because we certainly get records on how many people are on ADHD meds and what's happened to them. And so I think we will be able. I don't know yet how many will be on the ADHD meds, but I suspect there will be. Just in general in our population, they're pretty frequent, and so I think we will have some information on that question as well.
Okay, wonderful. Well, I don't see any other questions in the queue, so I just wanted to close us out and wrap up, and just thank you both again, Dr. Day and Dr. Lampert, so much for sharing your time and expertise with us.
Oh, you're so welcome. Thank you so much for inviting us.
Thank you.
And thanks to everyone who's listening on the call.
And for anyone who's interested, I'll send out a follow-up email with the link to the recording for future reference, and I'll also send out a link to our school resource kit as a resource for anyone who might need assistance with helping their child be supported within the school system. There's some great tools and resources in that, so I'll send that as well. Thanks everyone so much, and have a great afternoon. Thank you.
Thanks. You too.
Bye.
Bye.
Bye. Thank you.